So AI and machine learning are definitely hot topics in every industry, especially healthcare as well. Ophthalmology as a field utilizes various imaging modalities, and it is only a matter of time when it is well integrated with artificial intelligence as well. But we as ophthalmologists, how are we supposed to understand whether a predictive algorithm is good or even better than another algorithm presented to us? So I, Dr. Henal Javeri, present to you parameters for evaluating an artificial intelligence model. There are no conflicts of interest to declare. So my purpose of this presentation is to summarize the key parameters which a clinician must take into account when evaluating an AI model for clinical use in ophthalmology. We performed a literature review in PubMed, Cochrane, and Google Scholar regarding machine learning evaluation metrics, and the articles which dealt with the methods for evaluation were reviewed. The most commonly used statistical evaluation metrics for AI models in the background of healthcare and clinical ophthalmology are presented as a brief overview. So specifically in ophthalmology, there are two types of models which are commonly required. One is the classification model, the example for which could be deciding upon fundus imaging whether a patient has diabetic retinopathy or not. And for this kind of a model, what we look into account is the receiver operating curve, the area under the receiver operating curve, and the precision recall curve. Another type of model is the regression model, an example of which could be predicting myopic regression post-cataract, post-refractive surgery using pre-op data or fundus images. The parameter that we look for in this is the coefficient of determination as well as the mean squared error or the mean absolute error. So various technical terms that we do look and we must look for are the accuracy, that is the number of all corrected predictions divided by the total number of the data set. The best accuracy being 1, the worst being 0. Sensitivity or recall, that is when the patient has diabetic macular edema, how often does the test predict the same? Meaning, out of all the positive data points in a particular sample, how many did the model predict as positive? Next being the specificity, that is when the patient did not have DME, how often was the test able to pick that up? Precision, that is the positive predictive value, talks about how often is the model correct when predicting positive, and negative predictive value talks about how often the model is correct when predicting a negative outcome. Both these, that is the negative predictive value and the precision, depend on the prevalence as well, and therefore sometimes can be misleading. So the figure below demonstrates the receiver operator curve, where on the x-axis we have the false positive rate and the y-axis the true positive rate. So basically it assesses the performance of the model over an entire range of threshold. So we can decide upon this what cutoff threshold we want, and accordingly the true positive rate and the false positive rate are linearly related. In an imbalanced set, this could be misleading. Next comes the area under the ROC curve, which is just a single number that summarizes the efficacy of the model. 1 being a perfect classifier, and usually 0.5 that is chosen is a random, completely random classifier. Meaning that there would 0.5 would be the true positive rate, and accordingly false positive rate would also be 0.5. Next comes the precision recall curve, where on the x-axis we have recall and y-axis precision. So basically in this, just give me a minute. Basically in this, the number of true negative results are not used, and overall the curve which appears above the other one on comparison has a better performance. Similarly, in a regression or model, we'll have a mean absolute error, and an R-squared model would have a basically a value between 0 and 1. So in conclusion, the end goal of creating an assistive technology is to improve the service and the patient outcomes, which depends on clinicians using this tool, and it is very imperative that they understand the tool as well. Thank you.
I'm afraid I have a slight doubt. What is the study about? You did a literature review. You've not mentioned anything about what you have
Actually, there were only about 3 studies which were talking about evaluation of the various parameters in an artificial intelligence model.
So you have done a
So
statistical analysis of these, or what?
no,
was
so
it?
those studies were basically talking about the most commonly used methods and explaining the same for a healthcare provider. So that is what I took a brief out of that and I've presented the same.
Kind of a review.
It's a literature review, but it's not a systematic review. You just this thing did you look for, search for, cite?
So ma'am, we've checked in PubMed, Cochrane, and Google Scholar. Those
Most
three.
of these AIs will be in the engineering groups rather than medical.
Because
And
we were looking
diabetic
specifically for somting related to medical.
No,
That's
it
why.
is
what is the
related to medical, but it will be in the engineering stream.
Okay.
What
So
is the
you won't
final
get-
message to the audience?
The final message is that in the two commonly used models are the classifier and the
No, no,
regression.
just one line that this will help clinicians. That's it.
At least
Basic-
in which disease,
Pardon?
at least in which disease in ophthalmology do you think it's better now, as of now?
There's a lot of progress with regards to diabetic retinopathy that we are seeing right now. So these models would be, there are multiple models on the same, and therefore an understanding on which model would be good and the evaluation of the same is helpful.
Have you personally used any of these systems for your?
So we've been carrying out a study regarding fundus imaging for diabetic retinopathy using such a model, but it's still, we're in the middle of publishing it, so we cannot kind of disclose the results at present.